Good evening, everyone. We're going to give just a few more seconds for people to get logged in after, I'm sure, a busy day. We appreciate everyone joining us. It looks like we're just past the hour here, so we'd like to welcome you to tonight's AO Trauma Hand North America online series, 3 cases on fireside series of distal radius fractures. I'd like to thank Dr. Rizzo and everybody at the office at AO for organizing the whole year and educational activities. And in particular, my colleagues tonight. My name is David Dennison. I'm joined by Dr. Thomas Fischer, Sonya Agnew, and Keely Elwood for our panel here tonight. Here are our financial disclosures for all of our colleagues. Our validation statement for AO North America. And ways that you can obtain your CME credit. Please keep in mind this session will be recorded if you need to return to any of this. Zoom etiquette, your question and answer will be the main way for communicating with us. So feel free to use the question box. We'll do our best to answer live or in bulk as we go. Our agenda for tonight is opening remarks and introduction. I'll do a case with evaluation and management. Dr. Fischer will go through how I do it, lessons learned. Dr. Agnew will be looking at navigating complications. Keely Elwood will look at therapy discussion. We'll come to a few cases and then adjourn approximately 15 after the hour. Here are our objectives for everyone. I won't read them all. I'll let you read them for just a moment. And hopefully that'll be clear in our discussion as well. Upcoming webinars, 2025, complex distal radius, May 7th, August 20th, scaphoid non-union, and then December 3rd, failed carpal and cubital tunnel syndrome. Additional online series coming up for the mangled hand with Dr. Gupta, radial heads with Dr. Jupiter, and extensor tendon imbalance with Jerry Wong as well. I would like to also plug the AO Trauma Hand North America Fellows and Chief Residents course, which will be in Cincinnati in May 15th to 17th. We have a large tuition reduction based on a grant. So if any fellows or chief residents or senior residents in hand surgery at your program are interested, we have some slots left. We'd love to have them come. And the last thing would be the hand wrist fracture management, November 1st, 2025. So lots of things coming up for everybody to keep an eye on. This is also recorded through YouTube, AO Hand North America, and OrthoTV, which is recording it live right now as well. So with that, I'm going to switch my talks. Let's see. Sorry, Chris. Is that one coming up? I'm sorry. I did the share, but there we go. Okay. And I think I have to switch that. Is that still switched?
Yeah, you need to switch that.
Looking good there?
Looks good.
Okay, finally, we're off and running here. So for my first case, we're going to go over a little evaluation management of maybe a little more garden variety problem. But we'll start with a case. This is a 62-year-old gentleman who fell off a ladder, and he had quite a bit of pain, actually, so much so that he was seen in an outside ER, called our clinic the next day. He had been referred in and demanded oxycodone, and we had never met him. So a little tricky. He kind of cursed out the nurses, which was not ideal. This was his lateral and his PA, but he was kind of uncomfortable. Fortunately, we were able to get him into the clinic and evaluate him, and he was okay. But just a reminder, he was a little bit these can hurt, and he was upset, and it settled down and everything was okay. But my overview for just the section I'm going to do in particular is just the way I try to make sure I go into each case understanding the wrist injury and the fracture, not just the fracture, and think about how to choose a surgical treatment that I can get to the fracture to do the reduction and also put in what I need to stabilize it, hopefully through the, minimal incision, but also trying to minimize risk, excuse me, and minimize complications in the OR and to detect them, whether it's instability or where a peg might be in the wrong spot by making sure you're looking and using your mini C-arm well. Post-operative care, we'll come back to a little bit more. I'm going to leave that for Keely. Just to start with, thinking about our fracture, not to skip over the basics, but we want to keep in mind the importance of articular alignment, length of the radius, inclination, and the general parameters that most of you are quite familiar with. I would also call your attention to the obliquity of the sigmoid notch. Most people will have this leaning towards the ulna, but a small percent, about 12% by Tollett, suggests they'll be opposite obliquity. But the bottom picture here on the right, this is a displaced fracture. And when we do look at our reduction, we do want to not only look at the length, but maybe also make sure the sigmoid notch is returned to its position. That will in turn help the TFCC be back where it belongs in the ulnar styli, perhaps. Just something to think about. So when we look at our injury film, we can see this isn't too bad. There's a little bit of shortening here on the intermediate column. This may or may not be translated a little bit. Scaphoid facet is displaced and unstable. Fortunately, the SL is not too bad. The type 2 lunate, just out of interest. And on the lateral, for those that aren't familiar with it, the teardrop angle can be very helpful to look at your displacement in an injury and also how good your reduction is as you get to that point in the operating room. Dr. Medoff described this to be about 68 to 70 degrees. It's something that it's just a good reference. And when you look at our injury again, you can see that that teardrop angle is obviously, way off. Fortunately, this is a large fragment. The wrist is dorsally translated as well. So this fracture would meet a C-type fracture, multiple parts, being the dorsal and volar lunate facet, as well as the scaphoid facet. Fortunately, the metadapsal region is a bit more intact, and the ulna was intact as well. CT scans, I think, can be very helpful. In the beginning, we'll talk about this a little bit throughout our hour, but as you get more used to this, you will be able to define where every piece is. I think CT scans are helpful for me to be more confident about the plan that I have. There's almost always more comminution than you think. But at least here we can see there's a reasonable volar lunate facet piece. There's the dorsal piece. Hopefully that will key in relatively well once we reduce this. And this can also be helpful, I think, looking for other fractures such as a scaphoid, which probably only comes up about 5% of the time, but it's nice. And by the way, this CT I chose because it really wasn't one of the better ones we've had here, but it still provides some detail about this scaphoid facet. And I would say also a fairly narrow volar lip here, or the teardrop's kind of narrow, if you will. That's just the way this gentleman was. And here in the coronal plane, we can see the displacement. Fortunately, a relatively big piece on the intermediate column, and the radial column is clearly displaced. And again, CTs are just nice because it may identify some things that you might not want to try a volar plate for, or how are you going to address these fractures more independently for each fragment, for example. You don't need a CT for everything, but I would certainly get them if you need them for your comfort. I would say don't forget the survey. This gentleman came in, he had a lot of pain, his arm hurt, his elbow hurt. Fortunately, nothing was off on his elbow. But sometimes it's easy to, depending upon where you are, patients may or may not get that imaging. So if you're confident about it, great. If not, the survey is a great idea, especially with the higher energy injury. So with that, we've evaluated the patient. He's got a fracture. It's closed. He's doing okay. No carpal tunnel. And then it comes to what I go to clinic with every day, which is if I'm not going to fix something, I'm going to cast it because I think splints aren't, or use a sugar tongue splint, something that's not removable in the first few weeks. But for the operative indications, I think this meets them. There's a fairly big articular step off, and the radial shortening is there as well. And the tilt is obviously extended. So I don't think there's much question that we would offer this gentleman surgery. I mentioned the vitamin C. I do mention it at the time of the pre-op visit. Not much harm in doing that unless somebody has really bad kidney stones, I think. And it may or may not help, but I don't think it hurts. Moving ahead to looking at the 4 parts of this fracture, I think the column theory you're going to hear about more is really a nice way to think about this. I was taught by Dr. Berger about fixing radius fractures, and we tend to fix the intermediate column first. It was just a nice way to make sure the sigmoid notch was hopefully in a good spot. But Rickley and Regazzoni showed this as nicely that we can think about an intact ulna or not, an intact intermediate column between the Lister's tubercle and the sigmoid notch, or the radial column. And then also what we would consider the pedestal down here, or the distal metadiaphyseal fracture or bone, excuse me. If it's fractured, you may have much a larger zone of injury. But taking this and kind of building on the initial Malone classification, we can think about how to fix these pieces. And I would just highlight this. We'll talk about this a little bit tonight. Also, the importance not only of the articular alignment, sagittal plane alignment, and things in length, but to also correct the coronal plane, as it may also help tension the sometimes present distal oblique band of the interosseous ligament, as well as just allowing the TFCC to land where it probably should, and maybe minimizing risks of DRJ instability. So onto our case. I think with the parts, the most common couple of ways to fix this fracture would be some form of fragment specific, not necessarily pin and plate. There's multiple options now with plates that have locking pegs, so you can do it a couple different ways. I chose in this case I wanted to use a volar plate. I thought I could get around to each piece and secure them as long as I could get a good reduction. Volar plating has multiple advantages. I'm sure everybody is quite aware of these, but you can see the reduction well. There's a good spot for the plate. It's a fairly common approach, I think, in 2025. And we can hopefully preserve some dorsal soft tissue as well. So in this case, this is a representative case, so it's not exactly the gentleman, but I'll come back to him. So just showing, I tend to use a distal FCR. I go radial here just in case I need to get up to the styloid for augmenting the styloid fixation or anything. But in any case, just coming down the typical exposure through the hematoma, FCR, ulnar for now, trying to protect the median nerve and any palmar-cutaneous branch that could be there. The peroneal chordatus is lifted up, and just one of the hallmarks, I think, is getting to this volar corner. Then I'm going to be able to see my reduction nicely, hopefully. If this is comminuted here, these fractures are much more difficult. You're going to need traction, somebody to help, or something else to maintain some fixator, some distraction while you're working on these. I also would call attention to this really nice photo, just showing, the vessels. I try to leave the ulnar blood vessels if we can. That's where most of the blood supply comes into the radius. So we try to just get down here enough so we can see what we're doing, enough room for the plate, but maybe preserve a little soft tissue if we can. I can't prove to you that it matters, but I like to do that. And I think there's a very powerful tool in your toolbox, the brachioradialis tenotomy. If you're trying to get some length back, or if it's a very shortened fracture or an osteoporotic fracture, you don't want to push on too hard. This will take a lot of the force off that you can now just work through your comminution. You want to make sure you find your first compartment tendons slightly on the dorsal side of that. Dissect it off the styloid if you're not quite sure where it is. And Dr. Orbe, when I was a fellow, was kind enough to teach me how to do the Z step here and then use a tail of this to repair the pronator at the end of the case, which is a nice little trick as well. But and also keep in mind that you can pronate the proximal radius to get an indirect reduction of the joint surface if you need to. So we certainly use that as needed. Patients have a little bit of pain, I think, from that, but it can really be very powerful when you're trying to get a reduction and get around the corner. So the lift maneuver is the next step. We're going to lift with the Homan so that we can reduce the radial shaft to the epiphysis, because this is sitting on the ulnar head. So we lift the shaft and then we can lock this in. A little ulnar deviation, a little palmar translation in the lunate, a little flexion, a little traction will generally hold it there long enough. A bump underneath the palm with the supinated forearm can help hold that while you lay your plate in there, or some people might temporarily K-wire or pin this to get reduction. So just a couple of tips that have served me well, also trying to preserve those little vessels you can see. So with doing that, we correct the translation as well as the length, the sagittal plane, and hopefully restore some tension to the soft tissues distally. Our plate's going to come in, just keeping in mind that I showed a narrow plate here. Not everybody is a standard width. Some people are narrow, some people are wider. You don't want it too wide to cause a problem, but in this case, this was a smaller wrist. But for our gentleman, we did the same thing. He had a little bit wider wrist. I chose a wider plate. We reduced the intermediate column palmarly and then secured the plate initially using a blunt retractor here as well, trying to minimize any injury to using a sharp retractor. The scaphoid facet's pretty good and maybe not perfect. The lateral view, once we've reduced the dorsal and the volar lunate facet together, this looked pretty good. I couldn't see any step off. I would say when you see a step off on the fluoro, it's way off. So this looked pretty good, I thought. We kept it. We did not do an arthrotomy or arthroscopy and stabilized the intermediate column. And then once that was okay, I would call attention to this too. His volar lip was very narrow. I drove this plate as far distal as I could. After this point, it would probably start to tilt the distal radius into a little extension. So we had to let it float there a little bit. Could be a little closer to the subchondral bone, but seemed to be in a good enough spot. Then we turned to the radial column and secured that after compressing. Actually, if you use a large reduction forcep from your pelvic set, you can go from this hole or portion of the plate to the styloid and just kind of click it in. If you can't see it well enough, I would do personally probably a small arthrotomy or arthroscopy to check, but it seemed like it was in pretty good position. So we went ahead with our lock peg fixation. Our PA looked like this. I was pretty happy with this. Sometimes if I'm looking over here and I want to make sure that that ulnermost peg is safe, obviously you can rotate the forearm and get a few different pictures. The other view I really like is the modified skyline view with the wrist extended. And this can be really nice, as you can now see. Hopefully that'll project reasonably well, but we can see that the sigmoid notch is visible and our pegs are tucked way up into the dorsal ulnar corner nicely. So you can leave the OR pretty comfortable with that. The next step is to check the DREJ and make sure he's stable, which fortunately he was. We did go into it. I did place him in a sugar tongue to protect the soft tissue for the first visit or two. He also is a smoker, and I tend to immobilize those smokers a little bit more. I think they heal a little bit slower. But that was that case. Postoperatively, pretty generic stuff, but really making sure that he can move his shoulder and fingers. The elbow's a little stiff with the Munster we have on there. X-rays at 2 weeks. We've done some studies, and if you can get people out of immobilization by 4 to 5 weeks, they usually catch up pretty quickly. I don't have any problem mobilizing up to 4 weeks with a sugar tongue. Generally, the TFCC, I think, is just settling down. Usually that fracture is non-tender by 4 to 5 weeks, and we anticipate good DRJ rotation by 4 to 5 weeks. And then once they're 45 degrees, let them keep going as long as they're not having much pain, and really expecting that ulnar-sided pain to decrease by 3 months if they have it. So he did not require any TFCC or any other sided repair for that case. So hopefully that was a little bit helpful just to think about some column theory, how to use volar plate can really be nice for this. If we didn't have the reduction really nice on the, I think right about here is a decision, excuse me, sorry about that. I think right about here is a big decision point. If I don't like it here, it's the time to go in and fix it. And I think I'll leave it with that for my portion. And we'll move on to Dr. Fischer, how I do it, lessons learned, and appreciate your attention. Thank you.
Thanks, Dave. Back here to sharing screen.
While Tom's bringing that up, please feel free to use the question and answer box. We'd be happy to interact with you guys for the next hour or so.
So have you guys got presenter mode on there now?
It looks good.
See my screen?
Yes, it looks good.
Thanks. My talk is kind of in support of the radial column, and I really like the use of the radial column plate. So this is the outline. We're going to go a little bit over some of the implants. The columns, why important, and Dave's already talked about that a little bit, so I'll skirt over that. Reduction goals. and the relationship of the lunate fossa and the seat of the ulnar notch on the radius, and the load bearing as the ulna lifts the forearm through your fracture construct. And so I still like to talk about the nature of these fractures rather than using a big, complicated um, uh, classification system that not many people agree about. I like to look at bending fractures, shearing fractures, compression fractures, avulsion fractures, and then the complex combined, and then break it down by which column it's in. And so shearing fractures pretty straightforward. Those are the ones that even as a resident, I got to fix with the old standard 3.5 plate. So I still have a great love for that. Over 30 years now that people like Medoff and Rickley and Regazzoni and Matt Putnam and eventually Jorge Orbe all kind of came through with different types of fixed angle devices to fix these distal radius fractures. And you saw that you can use the old plates with an external fixer in combination. And I still use external fixators on rare occasion, but mostly my internal fixers are spanning plates now. And here's old cases with X-Fix using just two buttress plates, one on top, one on bottom, and then neutralizing it with the external fixator. And then Bob Medoff, who genius analyses of distal radius fractures really helped us to understand that. So here's our old X-Fix, and we still do that. We just take the X-Fix joints and put them on the surface of the bone, and that gives us our locked distal radius plates. So just a reminder, you want your radial angle about 5 degrees, palmar tilt at least neutral, and see if you can reconstruct it to a slight amount of palmar tilt. Now, ulnar variance comparable to the other side, our articular step off, like Dave said, if you can see it on C-arm, it's bad. And then the articular gap also you want to keep down to minimal, and sometimes you have to use arthroscopy to really sort that out. And your DREJ and ulna need to be stable in the radius after you've anatomically fixed or achieved these radiographic parameters. And so the rail column, as Dave turned out, was these three guys, and Rickley and Regazzoni really gave me an additional analysis on top of Medoff's articular fragment analyses. And so you've really got several things to go by here. And if you break down the columns, let me move this question and answer session here out of my way so I can see. And you see this big volar lip, and that's our volar bony buttress here. We've got a bony buttress here on the scaphoid fossa, the dorsal scaphoid fossa and the dorsal lunate fossa, far more shallow. So we've got this bony buttress for both the ulna as well as the lunate in this big teardrop. And that teardrop, even in small stature people, still takes up a pretty good percentage of the real estate. And then over here, you've got your first dorsal compartment with your insertion of your brachioradialis to sit over there and cause a disturbance of reduction. So I'm a free thinker when it comes to releasing the BR, just like what Dave talked about. And so our palmar surfaces are these broad, flat surfaces, and the dorsal surface is a little more sketchy as far as putting plates on, but there's plenty of real estate up there, especially if you remove the radial styloid and transpose the EPL. Your locked plates don't need a dorsal cortex that's much more than mush to be able to work, because it gets to that more dense volar bone. And you want to have your relationship to your ulna restored with the proper amount of rotation of that distal fragment. And so that EPL transposition gives you that landing zone for putting on oblique plates on the dorsal side. And then the 1-2 interval over here between the first and second compartment is a great place for a dorsal radial column plate. And then, as always, impingement on the capsule by implants, both the radiocarpal joint, but more importantly, sometimes the radial ulnar joint when you hang your implants too far ulnar. So there's a safe zone there, just like in the proximal radius. And remember that the lunate fossa and the sigmoid notch are inextricably linked. One, a fracture of the lunate fossa means a fracture of the sigmoid notch. A disruption or a malunion or a malpositioning of the lunate fossa means a malpositioning of your distal radial ulnar joint concave seat. And each of these load-bearing surfaces are quite dense, with the lunate fossa creating a great deal of density in the sigmoid notch. And so this is your money shot for bone density is right there at that corner of the lunate fossa in the intermediate column. The glenohumeral offset, we know a fair amount about that. We don't like smashed in glenoids when we're treating scapular fractures, shoulder fractures. Just like that, we don't like smashed in or translated in the coronal translation for the distal radius. And Moritomo, Hisao Moritomo, has done a lot of great work in analyzing the tensioning of both the ulnar carpal ligaments as well as the distal oblique ligament. And there are a number of biomechanical studies out there looking at that space relationship. And Dave showed you a little bit of the lift maneuver. You can use lamina spreaders, you can use Gelpies, you can use a fair number of instruments to recreate that translational gap between the two. And if you move that over with your if you don't move it over with your X-Fix or your spanning plate or radial column plate, you have to get some external instrumentation on there to get the reduction before you put your volar plate on. And here's one of my favorite instruments is the soft tissue distal radius clamp. It's sometimes called the Jupiter clamp because Jesse brought this out of South America where a guy by the name of Fernandez had developed. I think he's in Chile. And he developed this clamp and it's nice and flat on one side to put on the table, and it reaches over and holds your plate in place, and you can then push your fragments nicely. It keeps you from getting your thumb drilled when the resident's putting in the drill point to put these on. The nice thing about radial column plates is they orthogonally are applied, and they're quite a bit more stable from a biomechanical point of view. So here's an osteotomy. And I rarely did osteotomies later on in life without using a radial column plate because I didn't use a lot of wedge bone grafts. I just used cancellous bone. And this kind of construct will win your implant race against implant failure before the bone fills in, especially in smokers and osteopenic bone. So here's a translation maneuver that doesn't require external instruments where you just put your radial column plate on and screw it down with this one single screw. Screw's a little long here, but it's sticking in the interosseous space, and there's really not a lot of rotational motion there at that tip of that screw. So I usually leave it long, 1 to 2 millimeters, just to be able to hold that plate down. And it moves that, translates that over and gives you a reduction before you put your volar plate on. And here's a dorsal application of a radial column plate with a dorsal plate. And here's that translating force of the radial column plate as you put it on. And it takes a exposure like Dave showed in the Orbe type exposure. And here's that joint reaction force. When you lift your ulna, you're really lifting your forearm, and remember the radius is just along for the ride. You really don't lift with your radius. You lift with your ulna through the brachialis, through the brachialis, and you pull the radius up with it. And here's that lifting of the ulna with flexion of the forearm and loading of the hand and wrist attach the radius, and you really lift the radius with the ulna. So having a radial column plate opposite that type of force gives you a great amount of comfort with your construct as you're rehabbing the patient and they're out there lifting. I don't trust any of my patients to not lift things post-op, especially my farmers. So here's that radial column plate applied closely underneath the first dorsal compartment. But once you release the first dorsal compartment, I've never had a problem with instability. I've been using these radial column plates, either Medoffs or the AO system since the mid 90s, early 90s, and I just haven't removed any for problems of radius and ulna. So in summary, you got to follow the principles: anatomic reduction, stable fixation, preserve the blood supply, and functional aftercare. And I always say that if you fix a radius well enough that Keely and her hand therapists are going to love it, then you've done your job, because it makes their life easier, makes the patient's life easier, and you restore the anatomy and you can get back to where you need to be. I just want to mention one thing. This is an implant. It's a radial column, kind of internal brace that's a four screw and screw drum nail that my hand expert group polished up after a guy by the name of Lottie Naji, who used to be on our hand expert group, left the group, and he's at Valgris Hospital in Switzerland. And Lottie came up with this. It's available in Europe, not available in the United States, but it's going to undergo FDA testing. It's already CE approved, but it's for a two-part fracture with radial translation, and it's a very effective device for two-part fractures, and it's kind of a new wave of a radial column internal plate. So there's my end of my story. Thanks.
Thanks, Tom. That was wonderful. So I think we're just a minute or two ahead. I have to ask that there might be some people in the audience that, 20 years ago, dorsal plates were bad, right? Or 25 years ago, everything resulted in a tendon rupture. And then once the plates got smaller, 2024, that rupture rate went down. And then everybody said, well, we're going to do volar plates. And guess what? Volar plates had tendon ruptures too. So in your experience, do you think a nicely applied dorsal plate should be feared at all?
Well, I think the volume of the dorsal plate is what's sometimes the problem, and the lack of transposition of the EPL. The EPL is certainly at risk, but EDC is mostly at risk. And I call that area ulnar to the Lister's tubercle and radial to the prominence of the ulna. I call that the valley of death. And if you put any screws in the floor of the fifth or fourth compartment, they're really sticking out kind of ulnarly. And there's a wedge-shaped kind of trough there for the EDC tendon. So anytime you fill that with a big bunch of bulk, you're going to rupture your EDC tendons. But I think the modern flat plates that are judiciously applied, where the plate lies in the transposed area of the EPL and reaches up into that fourth dorsal compartment, they're smooth. Titanium is a little bit rougher on tendons than stainless steel because of just the nature of the chemistry of the surface. And you never can polish titanium quite as well as stainless steel, so you have a little rougher surface. I think your screws make a lot of difference. We used to use cruciate-headed screws. Now we use torque screws, where all the deformation of the screw lands are all internal and they're no longer on the surface. So I think the improvements in engineering of these plates has allowed us to reduce the bulk and smooth out the surfaces. The pie plate was the downfall of dorsal plating.
Yeah, plus the dorsal ones are often quite, you're on the side of the combination most times, and it's pretty strong. I think that I'm glad to hear what you said, because I always transpose EPL, and a lot of times I'll even take away the bone that's in the way there. If Lister's tubercle is common, to just take it away and let my plate be a little lower, almost, and just kind of, it can be really empowering. And I've never had a problem with the transposition. So
yeah,
thank you for
a 1-2, the space between the 1-2 first and second dorsal compartment is also a great little space to put. The radial nerve has always got a branch there, so you got to watch that. But it's always a great place to put a dorsal plate.
And thanks for the reminder of the Valley of Death. I'll remember that. So thank you. Okay, so we'll move on to Sonya Agnew. And sometimes things, you start with the best intentions and you have to work yourself out of some other problems. So thank you, Sonya.
Do we have my, can you see that?
No, it's not up yet. We see your browser. There it is. You need to switch or go to slideshow mode.
Okay, got that.
Looks good.
Good evening. Thank you for allowing me to be part of this panel. My name is Sonya Agnew. I practice at Loyola University in Chicago, and I have the dubious honor of talking about complications, which I feel I'm finally able to do with less shame now that I've been in practice for over 10 years. What I'm going to review are risk factors for failures, list indications for advanced imaging, which I think was a question in the chat box, and then describe the available treatment options for salvage, purposely hinting not at the specific complication I'm going to discuss. This is going to be very case-based, though. This is a tale of 2 distal radius fractures in the same patient. So a 47-year-old right-hand dominant, healthy male who's on a Segway scooter. This is a unprotected scooter going 30 to 40 miles per hour. He fell and sustained bilateral closed distal radius fractures with an open left distal ulna fracture. He's occupied as a musician, specifically a drummer. And I'm going to show you his initial radiographs, left and right. I will go into further detail here, but just have a broad strokes view of this and think to yourself, okay, so what could go wrong here? Is the complication going to be MISTI or EJ or TFCC injury? Is it going to be tendon rupture? Is it going to be malunion, non-union? And any number of one of these things can happen in management of distal radius fractures. So just looking a little bit more in detail at the left side, we've got a comminuted metadiaphyseal distal radius fracture with concomitant distal ulna fracture. We've got radial translation of that distal fragment as well as the palmar subluxation of the distal fragment. Overall, the interarticular extension looks it's present but non-displaced. And if we look at the right side, we've got more of a metaphyseal fracture with definitely some interarticular extension. And although I'm not a fan of eponyms, I think that the volar Barton is one to keep in mind because of the associated instability. And so you've got shortening, we've got some palmar subluxation, and then certainly some intrinsic component, some interarticular component of the fracture. So Dr. Dennison and Fischer both alluded to Dr. Medoff's papers or his work on the subject of analysis of the radiographic normal and abnormal findings. And I really think this is a absolutely essential reading for residents and fellows. Really kind of helped me understand what I was looking at, and really important for you to look at normal radiographs over and over and over again so you can get comfortable with looking at abnormal radiographs. The far left, you can see that the palmar dorsal cortices of the distal radius. The volar ulnar corner seems a little bit lower because it's typically tilted palmar. Dorsal cortex a little higher, and that's helpful in localizing these fragments when you look at the lateral. The teardrop angle, I always think of, looks like kind of like a Snoopy nose, and it does have a very characteristic appearance. So it's very helpful to be able to know what it looks like and then identify where it is in an abnormal radiograph. The other thing is the radial styloid, which you don't often pay attention to in the lateral view, but it is there, it's hidden, and you should be able to trace it. And then you can see here the widened AP angle here with a comminuted distal radius fracture. You can see the AP distance is real wide, and there's that Snoopy nose right there, that volar rim of the lunate facet. Okay, so here we are again. The patient's been seen in the emergency room. He has no other injuries. His pain is controlled, and he's undergone bilateral reductions. These are in-splint views. You get a little bit more detail, so it's subsequent x-rays, and you can kind of trace your lines, trace your Medoff lines. And so we're going to start with the left side. This is that metadiaphyseal one. And I usually start with the volar ulnar corner because sort of a theme you've heard here. This is a critical corner, the seat of the volar carpal ligaments, and the big buttress of support for the carpus. So that blue line on the left view is the volar carpal line, and then you can see it on the lateral and sort of match them up. Here's the dorsal ulnar corner. Here it is on the lateral view. The radial styloid on the lateral view. Ulnar styloid. So I think I have a pretty good idea of where my pieces are. And I feel confident that I know what I'm looking at. Let's go to the right side. So this is the right side, the more metaphyseal one. And we're going to look at our lines again. This is a little bit harder to see. So I think this is more of a pronated view, but we've got our volar ulnar corner. Okay, that matches there. We've got our dorsal ulnar corner. Styloids here. Can't really see the styloid there because of cast padding. Okay, here's the ulnar styloid. That looks like the ulnar styloid. Okay, I know what that is. But then I see these other lines, and I'm like, what are those things? So I go back to my pre-reduction images, and I try to correlate what I've seen in my post-reductions and look at my lines there. So there's our volar ulnar corner. Okay, I can see it there. I think that's a Snoopy nose. Dorsal ulnar corner. Yep, that's it. That makes sense. It's tilted. It's a little higher, a little more distal. There's my radial styloid. I think that's it. There's my ulna. Okay, that looks like that. All right, so I'm ready to go, right? Next steps. This is what you should be asking yourself. Am I going to get any advanced imaging? What's my approach going to be? Am I going to do volar, dorsal, radial, a combination of all 3 or 4? What hardware am I going to select? Am I going to choose volar locked plates, dorsal plates, frag specific, or a spanning plate? And let's jump in the left side. So this young Dr. Agnew did not get advanced imaging. She felt that she knew where the pieces were. This is the section on complications, I will remind you. And she approached this bilateral distal radius fracture with no advanced imaging. And I see everyone's laughing here. Go ahead, you can unmute and laugh. I'm confident. The right side, okay, remind myself, where am I going to go? I think I'm going to go volar approach on both sides. I think I can tackle this with a volar plate. Intraoperatively, let's do an assessment of our findings here. And Dr. Fischer and Dr. Dennison pointed out that any irregularities on fluoro really are really more magnified in real life. And so I'm going to be critical here and say, here's my volar ulnar corner. That looks well reduced. Okay, I'm satisfied that the plate's supporting that volar ulnar corner. It's a big piece. Here's my radial styloid. Looks good. Sigmoid notch looks relatively well aligned, although it's a little fuzzy. And then my intra-articular step off is present, but minimal. And I would say acceptable. I'm not going to take any screws out. And in this patient, I'm not going to go on the dorsal approach. I'm going to commit him to this. And I feel confident with this. So I'm moving to the right side now. Okay, intraoperative assessment of the right side. Same plate. At first glance, I think it looks like a relatively reasonable reduction on the AP, although it looks like maybe I have not corrected that radial translation. So could have maybe benefited from that sandwich plate, that orthogonal control of that radial styloid fragment. Maybe that inclination is a little off. It seems a little steep. I'm going to do my lines here. There's the volar ulnar corner. Okay, dorsal ulnar corner. I see maybe it looks like radial styloid there. Okay, that looks good. Okay, we're going to jump to post-op. So post-op on the left side looks good, looks the same. I don't see any changes compared to my intraoperative view. But this is the view that you see in clinic, and I'm going to assume that some others on this call tonight have had similar experience, where your stomach drops, your face falls, you're like, your day is ruined. You're like, oh my God, visceral response to these X-rays. So this fracture has fallen apart, and you immediately look at your intraoperative X-rays and go, what happened? Why did I miss this? What happened? What could I have done differently? And this is an unreduced and unsupported volar ulnar corner, amongst other things. But the real reason why this fell apart, in my opinion, is that the carpus subluxated with that piece. And so I'm going to trace that out here a little better. So now you can see that Snoopy nose, and it looks like it's kicked up a little bit, almost like it looks like it's over rotated. What is that plate doing for that piece? Nothing. It's not supporting it palmarly, really, and the screws are not supporting it either. So this was a setup for failure. But what do I do now? So this is about what to do with these complications. So you have this. You can pretend, if you wish, that this is a gift from the outside hospital. But it's my patient, and I own this. And I sit down. This is 1 week post-op, and I say, listen, the left side looks good. The right side does not look good. What do you want to do? Options include advanced imaging to get more detail. You could do nothing. Just let it heal like this. You can offer revision fixation. If you're going to revise it, what approach are you going to use? When are you going to do it? you could arthrodese him immediately. And this is where that shared decision making that we all kind of throw around comes into play. So the patient and I both opted for revision fixation. The reason was because I felt that volar hardware really was at risk, and I thought I could make them better. I planned for a volar dorsal approach with a spanning plate. I planned to have bone graft substitute available to raft up the articular surface and frag specific plates if needed. And this is what I hoped for. And when you think of me, think of this x-ray, okay? Not the other ones. I hoped for a little buttress plate on that volar rim, a volar ulnar corner fragment, so that I could just tack that carpus back in and something to support the radial column, which in many cases, a radial salad plate is great, or a screw and a washer is also helpful. But what did I get? He got a spanning plate and a close to abnormal articular surface. I used a suture anchor actually to help drag that volar ulnar corner back into alignment. The dorsal spanning plate though brought the carpus back into alignment with the radial with the radius. And then I used some calcium phosphate putty to support all of the mushy bone fragments that remained, 2 weeks after his injury and a week after his first surgery. It is really hard to fix these fractures at any time, but especially in that 2-week period, it's a mess. It gets harder, so I recommend going in early, but it's a lot of little pieces. And it looks funny here because when I put the dorsal spanning plate on, I put it on in pronation, which I no longer do because it kind of makes your radiographic analysis really challenging. So I advise people putting the spanning plate on with the wrist in neutral position as opposed to pronation. There's my radial styloid piece. Again, it's kind of pronated view. There's my volar ulnar corner. There's my teardrop. There's my dorsal ulnar corner. And all that mush in the front is calcium phosphate. So that will resorb with time. This is him 3 months post-op. Again, he's kind of pronated, not great views. He's definitely ulnar positive. I don't love that fossa view, but we'll get a better view at a year post-injury. And this is where he is. So ulnar positive, very much set up for radiographic arthritis at the radiocarpal joint. Clinical range of motion and outcomes. He's got 3 out of 10 pain. He's got 20 degrees of extension, remarkably, 30 degrees of flexion, probably through the midcarpal joint, 10 degrees of ulnar deviation. Thank goodness. I don't want any more than that. And 15 degrees of radial deviation. His pronation and supination isn't that bad either, though. He's pretty limited with supination, though, probably because he's so ulnar positive. He's very happy because he can move his fingers. And so, learning objectives for this case, let's review them. So risk factors for failure fixation. In my opinion, when you see a patient who has a high energy injury, you should really consider that this is a risk for failure fixation. These behave differently than low energy injuries. Any kind of volar ulnar corner comminution is a risk factor for failure fixation. And then bilateral injuries. And I think the reason is because you're distracted and you can be more tired, and you certainly can miss things or skip over things because you got 2 risks to deal with. Indications for advanced imaging. I think anything that has difficult to identify fragments on plain radiographs deserves a CT scan. I think we talked about that in the chat there. And then treatment options for salvage of failed fixation. Certainly you can offer benign neglect, but I don't recommend it, especially for young people. Immediate radioscapholunate arthrodesis is an option. I think he has a functional radioscapholunate arthrodesis. And then revision fixation, which is what he has now. I think the patient and I decided the right choice. He's happy. My biggest point for these kinds of complications is to stay with your patient. So when you get that gut punch and you realize you've got a complication, Perry Light kind of talks about this the best, and that the patients just want to be supported, and so sit with them and live with the complication with them, and that is all I have. Thank you for your attention.
Thank you very much, Dr. Agnew. I wouldn't say I think we were smirking because we're like, oh yeah, I've been there. Not so much. That's a tough one, and it takes a lot of gut to go back in there. And I think the longest walk I've ever had is from the elevator to the patient's room every time I had a patient in the hospital with a complication. But
yes, I agree. Your comment of Well, you remember this is a complications talk. That's what kind of triggered my chuckle. I've been there, done
Yeah.
that kind of thing.
So there was, I think we have just a minute here. So there was a question from, I think, Dr. Kadesh online and said, would the spanning it from the start work? And certainly that probably would be, who you're looking through your retrospectoscope, it would be probably a nice thing. I think we all use bridge plates, I would say much more commonly. I do in the last 5 years than I did in maybe 5 to 10 years ago. I also find the second compartment a little bit easier. Just two things. I like it for two reasons. One is I think it's easier for me to get there, and the other is that I think I get a little bit of that almost like radial column push by being on the second compartment. Um, as um, as Tom was talking about, I think being under the ECR and the CRB helps me kind of help push things over a little bit. But just um, the other thing I would say is how long if you're going to put a bridge plate on, like how long are you leaving them on?
I go 3 months just out of habit. I think you can certainly take them off earlier, especially if the fracture is really distal and the patient's healthy. But I really haven't seen too many problems with stiffness, and patients are really happy that they don't have to wear a cast. They really look remarkably normal with the spanning plate in place during that time. I have once taken one out under local anesthesia, which was kind of fun. So it is a trip to the operating room, but not the end of the world.
Yeah, it's interesting. I don't do them under local. I take them out under Mac local, but it is a trip to the OR. Absolutely. Sorry, Tom.
Mac local. I think 8 to 12 weeks, depending on the physiology of the patient, number of fragments, how much allograft you use, how much natural bone you use. I'm a big fan of croutons, cancellous bone formed croutons. They kind of stack nicely, but that's I think they absorb it just about as fast as anything else too, and reconstitute nicely. But that's a great question. I used to use a lot of external fixers and take them off the office, but then I got kinder and gentler and started taking them off under sedation in the day surgery.
I think in answer to the question, what I would do differently, I think it really would depend on what the CT scan showed. And I probably would have paid a little closer attention to that comminution. If I felt the fracture fixation was stable in that vulnerable corner and I really trapped all those fragments, then I wouldn't have needed to span it. But these high energy injuries, I think they're really at risk for failure no matter what your comfort level is intraoperatively. So I have a pretty low threshold with the polytraumas, especially to back up with a spanning plate. I just don't mind taking them back to the operating room. I think it's fairly low downside. And I go to
even if they have young bone, I think that tells you how much energy went through there to give you that many fragments. So I'm a big fan of multiple small plates and bone graft, lifting that center section up, getting your dorsal plate on, and then spanning it. And the spanning plate is a neutralization device. It is not a portable traction device. And just like X fixes, they are neutralization devices, not portable traction.
Yeah, great case. Thank you for sharing your learning curve with us. I think the other thing too is, polytrauma is one thing, and bilateral upper extremity, both wrists, is almost, not necessarily worse, but it's like, they're going to be using one of them. So yeah, it's a question of how much to do. There was a question about K-wiring. I would say certainly there's still value in K-wiring. I'll come back to that. We'll see if we can answer it. And then DSP to the second or third. I think for me, we could just debate this. I think second's a little bit easier personally. You're not getting under the extensors, and I kind of like that. But I think the third metacarpal plate, it can be nice when you're trying to depress the lunate a little bit palmarly if you really need that. Something that I learned from about for even putting on for bad perilunate injuries. But I think I'm not sure we're going to have an answer for that, but just to do the one you're comfortable with. I think we were just a minute ahead, and I don't want to take any more time from Keely. So we'll have some time for discussion in about another 5 minutes, and we'll come back to that. But with that, I'd like to thank Keely for joining us we worked a long time together in Rochester, and appreciate her joining us tonight to help us get our patients to look really great after we get to operate on them. Thank you.
Yeah. Okay, let's see here. Well, thank you for letting me be part of this. I think we get the easier task. We get patients after you guys do the hard work with surgery. My name is Keely Elwood. I'm a hand therapist. I work at Mayo Clinic in Rochester, Minnesota. I think the biggest thing after surgery, we get patients. I think the most important pearl, I feel like if there is any thing, is to try to get them moving early, being mindful of like finger motion. What can we move safely, with the fixation that's in place? And so when I have a patient in front of me, I'm thinking about the things they have to do even after surgery, whether both hands are involved, one hand's involved, do they have supports at home? Are they required to use a walker? The mechanism of injury, the pain that they're in, thinking about their cognition, how closely do we have to follow up? Are they able to understand, those directions, or do they need some more reminders, different ways of learning? And certainly thinking about, again, moving early. Can we start edema control with post-ops on, casts on, with, compression devices, expand, get those fingers moving. We want to make sure we're preserving that fixation. So with orthotic fabrication, I'll touch upon and show you some examples of that in a bit. And then also just other soft tissue needs. If they have swelling that extends, past the post-op up to their upper arm into the axilla, working with patients early to make sure that we're trying to manage and mobilize that. So when that post-op comes off, the cast comes off, we can get things moving as early as we can. Certainly maximizing function, thinking about soft tissue adherence, joint contractures, and then again, tendon gliding when we can. And I'm an OT first before a hand therapist, so I really think like ADL modifications, one-handed techniques. I mean, I feel like we see more patients now since after COVID that require, they're not being hospitalized, or, you're having surgery, they're out, all of a sudden they're going home. Like, are they able to get dressed? Do they have, sleeves that they can get on? What about showering? Making sure that we're addressing all of those things so they're able to be successful and keep that fracture safe in those initial healing stages. Just a diagram of some initial or phases of therapy. The first 6 weeks, generally we're protecting it in a cast, post-op sugar tongue, mobilization, but really wanting to make sure that their fingers are moving well. I think, when you're putting post-ops on, casts on, giving them as much room as you can for finger motion to allow for some tendon gliding, making sure they're able to, bend, extend that elbow, and that shoulder. Also, we're very mindful early therapy, watching for signs of some CRPS and pain responses, and also being really mindful if they're concerned about like a tight cast. Sometimes that can trap edema distally, and that can be a little tricky to manage. Not impossible, but tricky to manage with compression sleeves, some manual therapy. And then after that first week, or the first 6 weeks, 4 to 6 weeks, coming out of that immobilization, we'll look at getting into the splint if they need it, beginning some gentle range of motion. We're certainly mindful, or I'm always mindful if there's involvement of the ulnar styloid. Maybe we're being a little more cautious with forearm rotation, not pushing it, really being careful of pain through that DRUJ, and then again, managing edema. And then in this phase 2, also looking at that soft tissue, managing that scar with some scar massage, and then kind of closer to that 8 to 12 week, thinking about, strengthening, kind of more aggressive stretching if we need to, and getting them back to those like functional activities with the wrist and grip strength. These are just a couple of different examples of different orthotics. This is a material that we use. It's called a delta casting. It's actually fiberglass free, and it's considered like a knitted polyester tape. And so, it's formed very much similar to a cast. We can wrap it, but then we cut it with a bandage scissors, allow that bivalve so they can open and close it. This is a Munster version of it, but you can also kind of see on the bottom that we can make we call it a delta clamshell or volar wrist support. If the patient's having a lot of fluctuating edema, swelling that's happening, if they have cardiac or fluid balance issues, this can be a nice way where they still get a little bit of protection, but it allows for some of that adjustment with the fluid. Different types, we have that prefabricated wrist support, or we custom make thermoplastic splints. Exos can be nice for people that are maybe at younger, higher risk for those high energy activities, even when we're not quite there yet. The exos can be nice too because they can get wet. They dry a little bit quicker, a little more durable. Then we also have, we make clamshells, and then this is another orthoplast Munster, and then thinking to another example of a delta or a volar thumb spica. So I think sometimes, particularly like with older adults, we can see some CMC joint pain following prolonged immobilization or just that trauma onto their hand with the fall. And so that's also something, they can't move it great in a cast. Are we supporting that in the rehab process and just making sure that they aren't developing worsening thumb pain from changes or that stress on that joint from kind of overuse with that limited motion. I think these are like my biggest take-home message. We want to try to, if they show signs of limited finger range of motion or a cast that's too tight, or if they've had to come back for multiple class changes, they have some social things going on, or, you need extra help, make sure you try to get them to us as early as you can. It doesn't have to always be a hand therapist either. It can be an occupational therapist or physical therapist. They can be addressing some of these things too. I feel like I work really hard. I know the therapists I work with try to really individualize each treatment to what the patient needs, whether it's the self-cares or just working on the biomechanics as well. And then being mindful, watching for signs of pain or any sort of ulnar wrist issues.
Thank you very much, Keely. So I think all of us on the call, and I mean everybody, we really rely on our therapists, and they are our point people for, probably noticing things maybe before I do and saying, hey, someone's struggling or this or that, and really can help, because it's not super common that you get finger stiffness, but the sooner you identify it and get them some help, maybe not full-blown CRPS, but something where they're just a little slow, it does happen. And just team up with your therapists and your OT, and thank you very much for preparing everything, Keely, and for all the help over the years. So I
Dave,
think
on your first case you showed, you had a guy show up that was in intense pain, called, cussed out all your nurses, et cetera, and he had that big palmar spike. So when you see that, start thinking median nerve injury. Also start thinking occult median nerve stretch injury / contusion, whatever, but neuralgic type pain. And that's something you need to catch early and start treating early, because it can crescendo into CRPS type 1 for sure.
Yeah, great point. So we were grateful. I was kind of like, oh, great, have him come in. I can't wait to hear how this is going to go. But when he came in, I'm like, do you have any numbness? And he said, nope. Said, I'm feeling better now. And I'm like, okay, great. So we actually, in adults with those extruded pieces into the carpal tunnel and with any symptoms, I do a carpal tunnel release. Kids is another, we won't go into that, but kids, it's a little different. You may just do the reduction and monitor them. But I think if you have bone in the carpal tunnel with carpal tunnel symptoms, certainly going ahead with that is, much safer. I don't do many prophylactic releases. I think you can generate some scar that you don't need, but great point. Thank you for the reminder. But those high energy off the ladder, off the roof things, absolutely. So I think if anybody has some comments from what we did, I can't thank you all enough. I'll try to get on to a couple of cases just to make it a little interesting for our whole group here. I will try to get please chime in with any other
Actually, I have a question for Keely while you're pulling that up, Dave. So I read a study one time that indicated that patients see the highest frequency of complications, not malunion or non-union, but digital stiffness. And my question is how you empower the patient to move their fingers for patients who may not be as savvy or have a lot of pain. Is there any tips or tricks you have on getting them to move their fingers enough so that you can mitigate that risk of digital stiffness?
Mm-hmm. I think helping them understand the anatomy and that those flexors and extensors are crossing over the wrist. Just this week, I had a patient who had a volar plate in, and she was insistent in like my flexors are stuck. That plate is through my fingers. That's why I can't move them. And so, showing the anatomy, trying to give as much examples as we can. And I know the surgeons do a really great job. They're seeing everything when they're putting that plate in, and that it's pulling through that volar wrist because those tendons have to glide through that area. But especially too, like the forces that are used, that your muscles are not going to displace the plate that's placed in there. But you guys have to, so I think a lot of education and reinforcing that they're not going to do any damage, but giving them examples like, no, I don't want you lifting a gallon of milk with this hand. But yes, I want you to try to think about like scratching your face or, kind of gently working between your fingers, applying makeup or maybe feeding yourself a bite of food, trying to give very functional examples, I think can sometimes be a little bit easier for them to picture in that case too.
Super. Thank you very much. Can you guys see I apologize. I just want to double check. You can see my case presentation slide.
You need to switch to display.
Oh, again? Oh boy. Sorry about that. Looks correct on mine, but is that better?
Not yet.
Not yet. You're not seeing that 19-year-old scaphoid, distal radius?
Presenter mode.
Interesting. My apologies. This looks the same as what I had for all the other ones.
Yeah, I think if you go up, maybe not.
Let me try one more time. Sorry about that, everybody. Try one more time. I'm sorry about that. I don't know why it's not going. Any luck with that?
It looks good now.
You can see it? Okay.
Yes.
Great. Okay. Thank you. Sorry about that, everybody. So this was a while ago I did this case, but this was a 19-year-old patient. I forget the exact injury. I think it had something to do with tumbling, and presented with a closed fracture. These were the limited plain films we had at the time, and so I guess just for everyone on the panel, I think one question might come up is, does this need to be fixed or is it going to displace? And how aggressive are we going to be about that? And, do you need any additional studies? So,
this is that fracture that we all worry about. Can't really see that well where it's coming out on that palmar cortex, but if it involves that volar buttress, then depending on how big it is and if it's attached to the radial fragment, it may be stable. But if it's separate and you do see that split there, then I'd be worried that that's an unstable fracture pattern. Overall, looks pretty good. I think additional imaging would probably be helpful, either a live fluoro view or advanced imaging.
Yeah, sure. And I apologize because this was a little bit older, so I had the 3D. Oh, sorry, Tom, go ahead.
I was going to say, back on your plain film, whenever you see that density, increased density underneath the subchondral bone, underneath the sourcil, so to speak, of the dense subchondral bone, and you see that density extending proximally, it's just basically compacted cancellous bone that gives you that density. So I'd be highly suspect that there's a die punch fracture of either the dorsal or palmar cortex, and you just gave it away with your 3D reconstruction.
Sorry about that. Yeah, so this one just happened to show that the intermediate column here in the sigmoid notch looked to be intact, and the scaphoid facet is rotated a little bit along curl down here on the palmar side. So now the question is, what are we going to do with that?
And you can look for that density on the regular CT cuts. You'll see it quite clear, and once you look at it a few times, you'll see it commonly.
Yeah, and I find most of the time, I usually find the scaphoid facet is usually extended a little bit. The dorsal bone's a little weak. It seems to go back almost every time. So usually I'm working on getting it down over the top and then kind of lining it up a little bit with a K-wire or whichever. So in the interest of time, I'll just go on to say that we went ahead and did a arthroscopically assisted reduction. And I chose to use a single screw, and we checked the DRJ and repaired that it was a little bit unstable. So I went ahead and did do a DRJ, or excuse me, a stabilizing procedure with fixing the styloid. But I think there might be some interesting comments about whether everybody would fix this the same way or not.
The only thing I'd add is subchondral or dense cancellous bone screw transversely right across the distal. Yeah, just right across there. just to support that, to raft it up, if nothing else.
Yeah, I think I was a little, oh, sorry, go ahead.
No, I think this looks great. I like that one hole plate construct, the screw in the washer. I feel like it's nice. It gets good compression, but you also do have to worry that you can over squish it, and you can maybe have to back it up. And if you get that funny view where it looks like it's slid ulnar, then you gotta take that out and redo it.
Yeah, and to be fair, I'm sure that I backed this up. This person probably got casted more than maybe absolutely necessary because of the DRAJ repair as well, so, or the styloid repair. So we got away with this one okay. But just a little variety. So I'm going to jump ahead to, excuse me, sorry. So we're going to jump ahead to this one. So occasionally, we read that the academy says, guidelines say, well, if you're over 65, you probably don't need your fracture fixed, and you can just, but that's not always the case. So this is a patient who's 78, left hand, left hand, I believe, and she's pretty functional. She lives alone, and comes in, and it looks a little short here, and it's a little swollen. The skin's intact, but we have this lateral, and I guess curious what do we do in 2025 for the 78-year-old active patient?
Span it, span it, span it.
One vote for span. Okay.
Yeah. One vote for span, 2 votes for span, and just a little bit of a buttress on the dorsal side if it doesn't completely reduce the lunate fossa. The spanning plate through the second dorsal compartment does a great job of reducing the radial column usually, but sometimes that lunate fossa kind of escapes.
Keely, I wish one of your splints could fix this.
Well, I know. I was just going to ask with if you guys do the spanning plates, do you guys put them in post-op immobilization? Do you do casting? No splints? Nothing? I mean, we have a kind of a mix. Some surgeons here will have us make like a delta cast or something for like a little protection if they're like a high fall risk. But do you just let them go with? Okay.
I put them in a bivalve splint just because I don't want to ever have that second dorsal compartment or that spanning plate break. You can't trust patients.
Mm-hmm.
I've only seen these plates break in patients who fail to follow up, and they're well beyond the 6-month mark. And even then, it's the easiest thing to take out.
Mm-hmm.
They will break eventually, but I think one of the nicest things is that you can let these patients shower and your fingers really easily, and they look normal. You almost can't tell. So I don't immobilize them. Initially a 1-week period of post-op immobilization for soft tissue rest, but I don't immobilize them.
With them sitting right on the bone, they're biomechanically as strong as just about anything. So it's rare to have one break, but they can.
So I think the common theme there was most of us were leaning towards fixing this, and we did share the CT a little bit earlier, and it kind of shows that this is sort of effectively a fracture dislocation in a very osteoporotic patient. So in the interest of time, I will go ahead with what I decided to fix this. I thought it would be mean to leave her like this. Here's the lunate facet up under the dorsal cortex, which is probably the only time I've seen it look quite like that. Fortunately, there was no carpal injury. So we put traction on whether we were going to do a fixate or a bridge plate, but it didn't really get much better with that. So it did need an exposure. I tried to keep it limited. This is the dorsal cortex. Here's the lunate facet facing the ceiling, the lunate scaphoid, and then we just basically rotated it down. And there was such a zone of mush here that I think you definitely could put some other things in there. I kind of just, every K-wire I put in just felt like it wasn't doing anything. So I left the fixator on, bone grafted this, and just put a little plate to hold the wall down, if you will. It was really probably a very minimal. I'm not sure I'd recommend this, but it was enough to support this. We just enough traction to keep the wrist from getting leaning on it too much, and we were able to maintain that with an external fixator. So I think the point is that our 78-year-olds are, if they're active in things, I think it's reasonable to treat them, and you may have to individualize for these. And we'd probably, on average, I think I'll probably use a bridge plate. This was back when I just was using I still like fixators if I can manage them and can take them off in the office and spare the trip to the OR. So that was our final view on that. So
In
Any other
the very young patients, you'll see these kind of injuries where the distal radius just gets decapitated and the articular surface gets sheared off and it flips over 180 and it's facing backwards. This one is impacted into the distal metaphysis. That's pretty impressive, but yeah, the upside down articular surface in a young high energy patient is a tough problem to take care of too. Needs a spanning plate and reduction.
Thank you, Tom. So I think in the interest of time, I'm gonna share one last thing. I just wanted to kind of share with everybody just for a second, because one of the questions that didn't come up a whole lot, but there's often the question about what to do with the distal ulna. Just to say that if you are faced with an unstable distal ulna and it looks like the ulna is going to converge with the radius, essentially, that if you fix the radius and you've already got your coronal plane correction, but the ulna is not cooperating, right? It's really just the radius falling into the ulna. It's okay to kind of think about getting that space rebuilt and getting the soft tissues tight again. And the way you can do this is convert this to this, left to right. And the way it can be done is another plate here that can really just work on bringing the shaft back away from the radius, if you will. And just a little tip in case you get that situation. Otherwise, I think most of us would try to leave distal ulnas alone if we can, if you have good DVR, a volar plate construct. But just a little tip. And for just to kind of cover this very quickly, if you have your distal radius stable with a nice plate and the DRJ is stable, you don't need to fix the styloid. If you think it's unstable, fixing the styloid or the TFCC would probably be the way that most of us, I think, would manage this, or at least neutral alignment and a sugar tongue splint and seeing if you can get enough stability. As long as they have good rotation in the operating room. If they have blocked rotation, it's your obligation to fix it, to find out the problem, whether it's sigmoid notch or something else in the sigmoid notch or the DRUJ. Sometimes that's pretty rare. This is just a slide showing that your instability will be there with or without your styloid fracture. So you should look for the instability. It'll be there just as many times without the styloid fracture. So really only treating those if there's instability of the DRUJ. So for our summary of our current treatment, I would say we don't really have proof that any one treatment is better. ORF is probably better for younger patients, earlier return to activities. Keep in mind, volar plating has several advantages, but this is not without morbidity as well. Try to limit your complications. We saw a couple comments about planning ahead. Of course, we want to plan ahead so you don't fail. If you fail to plan, you may plan to fail. So keep in mind the age of activity level of the patient. Treat the patient, not just the fracture, as well as just a reminder for treating the bone, treat the osteoporosis. My fellowship was really great, and I was taught to be prepared to use several techniques, obtain reduction and stable fixation. Make sure you can use your fluoro to really detect and understand, just like Sonya shows beautifully, how to see all those pieces and make sure you can tell where they are. And if you can't tell, you should keep looking. And I would just leave with trying to minimize retraction, over drilling, long screws. I oscillate things instead of spin them, just little things that might keep us out of trouble. And with that, we'll wrap up. Thank you very much for attending. We'll try to answer, I don't know if we can answer other questions. We'll see if we can, but just like to thank everybody, Keely, Tom, Sonya, and everybody in the AO office tonight, and Chris also for supporting the webinar tonight. Thank you and good night.
Thank you all.
Thanks.
Thank you.
Thanks,
Recording
Andy.
stopped.
That last slide was too soon for me, Dave. If you can't find the pieces, keep looking. Dang it. I go back in time. Maybe I should put that in the next webinar, which is like complex distal fractures.
That was a super case you had, that the bilaterals. By the way, nobody until a couple people on the call do that. You finish one side and then you have to get like ready to go to the other side. And you're like, oh my God, I just spent hours.
Yeah, that's the power of partners.
Totally. I think I used to be a little afraid to ask for help. But now with the bilateral, I'm doing the patient a service by not getting tired before the work is done by looping in my partners. So
wait till you get old, Sonya.
I already have low back pain. Thank you guys.
Hey, Jimmy, my son James, who interviewed with you, Sonya, he said to say hi because he remembers you guys talked about movies when he interviewed for his hand fellowship up there.
I can't. It's like that's my go-to conversation is movies. It's like, quoting lines from movies, and I can. That's the equalizer. I don't know anything about sports. Movies works for me.
Yeah.
Tell them I say hello, please.
All right. Take care. Thanks,
Right,
Dave. Thanks for inviting
No,
me. Appreciate it.
thank you guys.
Really nice to meet you virtually.
Yeah, nice to meet you guys. Thank you. Thanks,
Thanks.
Dr. Dennison.
Oh,
See you around the horn.
thank you, Keely.
Yep.
Bye-bye. And
Bye.
Sonya, I'm sorry if I hope I said I didn't, I should have asked you to make sure I didn't know if I had the pronunciation exactly the way you like it. So please teach me if I'm,
You mean my first name?
yeah.
Oh yeah,
Did I
Sonya.
say it?
Yeah,
I'm not, I think, we have a, I don't know if sometimes Keely, I think of our friend, and I wonder if I had the inflection a little bit different. I'm sorry if I
no worries.
said A's instead of E's a little bit, or I's, but
I grew up in Canada, and so I grew up Sonya, but it came here and it became Sonya. And
so
so
yeah, that's what I mean. Like, I think I'm not sure
Yeah.
if I gave the Canadian or not, but
I answered both. So yeah, no worries. I thought you were gonna say Agnew, and I was like,
oh, no.
Agnew.
I wonder
Spiro,
if I can
Sonya,
still
what
answer these
part of
questions
Canada-
or not.
What part of Canada did you grow up in?
Toronto.
I wonder if I can still
So,
answer these questions.
yeah, I've been a Canadian landowner for some time, so I pay my Canadian taxes,
Where?
Rainy,
Radial.
northern Ontario, just north of International Falls, about 30 miles.
What town?
It's Fort Francis, or
Okay.
north of Fort Francis, yeah.
Hmm.
Right, Lake of the Woods area,
Oh, Lake of-
international.
Oh, okay, gotcha. Yeah, that's a little further north.
Way northern Ontario, but still Ontario.
Is that near the big national parks,
Quetico.
Killarney, and I can't remember. It's beautiful part of the world.
Yeah, we're west of Thunder Bay, even.
Okay. Wow. Good
We're
for you.
west of Lake Superior. But anyway, bottom line is, I come up through Eau Claire now that I know Dave's there. I'll throw trash out the window as I go by. So. What clinic? What part? What office is that? Is that a Mayo office over there?
Yeah. So it's kind of affectionately over here called Mini Mayo. It's a pretty busy. There's lots of Mayo Clinic health system hospitals, but Eau Claire is basically as busy or busier than Jacksonville or Scottsdale compared to. So it's a very busy place.
It's got such a huge catchment area around there, so that's
Yeah, we've got a
probably
2-hour window on any side that it's an hour and 45 to Rochester, almost hour and a half to the cities, and everything else is across the state to the way to the east. So there's quite a bit of stuff, and people here like their liquor and their ATVs and their things that generate lots of. But yeah, actually, my partner, we are down. There should be 3 or 4 of us here. It's currently me and my partner, who's Lacey Flipson, who I hope you can all meet. She's been wonderful, half plastics, and we're pretty busy most of the time. Talking about partners, I think we get to work together a little more than I ever got to work with anybody in Rochester, just because of the Blue Orange Day, and some days we're in the OR. It's really great, and stuff. So yeah, it's a different thing. We actually have about 5 therapists now. It's growing, and it's got a pretty similar Mayo, just a smaller feel. It's not quite as all the bells and whistles, but fortunately, Lacey and I can take care of a lot of things here, and I don't have to send them elsewhere. And patients don't want to go anywhere. And you go, hey, you can go to Rochester. They're like, I don't want to go to Rochester. Nobody wants to travel. So. But anyway,
Yeah, I used to maintain an office in Terre Haute, 88 miles. It's my hometown, and I couldn't believe that people didn't want to come to see you. They didn't mind going to Indianapolis to get operated on, but they never wanted to go more than 5 miles to go for follow-up kind of care. So it's a pretty interesting phenomenon. All right, you guys. Time to go watch some basketball.
Yeah, good night. Bye.
Thank you, guys. Good night.
Thank you all very, very much for your time and preparing and everything. I appreciate it.
Thank you.
Yeah, thank you. Bye-bye.